Ladies and gentlemen, could I ask you to make your way in, please? We have more seats than people, and the best strategy in those circumstances is to gather in close and feel intimate and connected and in communication. And it will help prevent the anomie that would arise if you're sitting out in the cheap seats. Great. We're expecting a few stragglers, but I think we will make a start because there's food to be delivered later, and I'm instructed we may not be late for the food. My name is Michael Anderson. I'm CEO of MedAccess, and it's a great pleasure to welcome you here. My main job right now is to hand over to our chair, Professor Helen Rees, who's going to take us into the evening's discussion. Helen, do you want to come up?
Good evening, everyone. Very nice to see you. Michael was saying to me earlier today, next year should we have the in-person meeting in September or December? And I'm looking outside and I'm thinking, okay, I'm from Johannesburg. We'll leave it at that. But it's great to meet you. And I think I'm looking forward to tonight's discussion as well, because we're moving into new terrains, definitely. And I must say, they've turned them off, but the slides that were on before were, I thought, very simple and very informative. And the thing that really struck me was the 530 million people reached in 95 countries. And then also in this discussion with the panelists, the difficulty of doing innovative financing and the need to adapt the business model as you thinking on your feet and where we're all going to go. But MedAccess is a very successful, newish still, entity, which is shaping itself as it goes along and responding, I think, as it has had to go along. And we all know about responding to COVID, but we're responding now to quite a lot of different challenges. And we're responding very much, obviously, still we're not post-COVID, but we're out of the pandemic emergency part for now. And what we're responding to is where to from here in terms of pandemic preparedness and in terms of fear of outbreaks. And the focus has been a lot on infectious diseases, as we all know, and for very good reason. So what's happening now worldwide is that there's a negotiation going on through WHO, which is on the so-called pandemic treaty. It's probably going to be called a pandemic accord. And that's got all the member states. It's a very high-level strategic discussion that's going on. And as you can imagine, there are things which everyone agrees on. Do we need to work collectively as a global good? Yes, we do. Do all the member states want to work together? Kind of, yes, they do. Do they agree on everything? And you can probably imagine the stuff that's difficult. And it is the stuff like intellectual property, like specimen sharing, and who gets the benefits of a specimen. And data sharing, and even the complexities of something like One Health, because One Health, as you know, is the interface between animal and humans, particularly with infectious diseases. And with that interface between One Health, the question is, who's going to pay for all that surveillance? We can't even do surveillance on humans. And now we're saying to the poorest countries in the world, and by the way, go and survey your wild animals. So who's going to do it? Do we need a separate treaty? So you have the INB on the one hand, and then you have international health regulations. That's also really cranking up. And people are re-looking at those international health regulations. They were written and launched from 2005. Were they fit for purpose with COVID? No, they weren't. They really were to stop blockages of movement of people and movement of goods and trade. So they really were not necessarily designed to say, what do you do in a pandemic? And if you think back to that 2014 Ebola outbreak, what actually happened with those IHR regulations? those 3 countries in West Africa were completely cut off. People stopped flying aeroplanes in. They stopped giving goods. They stopped supplying medical supplies. So IHR needs to be also refreshed and rethought. And one of the things is what's called the core competencies that countries need to have to be able to respond to pandemics. And one of the things that we know is even the countries that scored relatively well, if we're thinking of low middle income countries, prior to COVID, when COVID hit, those core competencies didn't mean a lot. No country was prepared. So the IHR is also being revamped in parallel to this pandemic treaty. And then we have the absolute need, and this is where MedAccess comes in with this incredible model that is, as I say, shaping and evolving. It's an incredible need around equity. I was saying today that the IMB Accord in the draft form has got equity on every sort of 4th line. Equity is the driving force. And equity means that we have to invest in the poorest countries. And not only the poorest countries, but the countries that can't afford, which can be middle-income countries that lack subsidy. So we have to find this model of innovative financing. And MedAccess has been very successful at doing this, and has also hit some very sweet spots. For example, with the malaria bed nets, the RTSS malaria vaccine that's now been launched, with 500 million children still dying in the African region for malaria. If you speak to health ministers in the African region and you say, prior to the RTSS, what would you like most of all? They said malaria. Everyone would say, in the malaria zones, we have to do something about malaria. It's seen as absolutely a crushing burden of disease, and it's felt in communities because it affects so many young children. And then diagnostics, because the one thing, again, if you see writ large in that pandemic accord, it's surveillance, 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 surveillance. So diagnostics in all their shapes and forms. And this will be diagnostics that are suitable for laboratories, but are cost-effective. We're talking about things like HPV diagnostics, but it's also the diagnostics of self-testing. So HIV self-testing, combination tests, HIV and syphilis. And so MedAccess's thinking is very much at the forefront of that. And things like antimicrobial resistance. And some of the drugs you might say, niche market, we were just saying the same thing. But actually it's a niche market of where antimicrobial resistance is going to become a major, more and more problem. That's in places like intensive care units, even in low-income countries. This is where you're seeing these emerging multi-drug resistant organisms. And if they get a hold, we are going to lose the ability to treat infectious diseases. So antimicrobial resistance. I mean, if you look at the products that MedAccess has supported, it's hitting the nail on the head in terms of infectious diseases in particular. And what we're going to be talking about is now the movement into non-communicable diseases. With that, I'm going to stop and we're going to show a video, and then I'll say a few words about NCDs and where we're going, and then hand over to our panel as well.
MedAccess partners with suppliers for one primary objective: to improve access to health products.
Our guarantees can pave the way for doctors to have access to medicines, access to product innovation.
The challenge for us now is to bring forward how quickly we can bring new medicines to new markets at lower prices more effectively. And that's what MedAccess is for.
Thank you. That last sentence, Michael, from you was spot on, I think. That is the challenge. And the speed is something else that I think we need to also be really thinking about. And again, COVID taught us this, and many of you here will have heard of CEPI, which is looking at neglected diseases and development of vaccines, and they've now got an ambition for 100 days to get a vaccine from something that's on the shelf out into the marketplace. So speed is becoming a huge issue. So one of the things that is happening in MedAccess, I mean, I've been the chair for a year, is that we also having new colleagues. Diana Noble is here, who is retiring as chair of the investment committee, and Anthony Ross is taking over. We're delighted, Anthony, to have you. And we'll say a few more words about Diana later, but just to say she interviewed me for the job here. So I'll say nice things. So I think that, you know, that this is really changing. BII continues to be an incredible supporter of MedAccess because they get the vision. And the vision is one, innovative financing isn't something, you know, they say, what's your 3 sentences in an elevator? What's your elevator speak? It's quite a difficult elevator speak. Can you try it? So it's something that you have to get your head around, but it's going to become absolutely critical importance. And we're hearing also from Ghana, from the idea of health insurance and why we need to be thinking all the time about affordability and cost. It's going to become more and more important. In 1948, when the national health system in this country was launched, healthcare was a fraction of the cost of today. Look at some of the things we're looking at. We're looking at cancers now. We're looking at radiotherapy. We're looking at biologicals, monoclonal antibodies. We're looking at things that are hugely expensive. Healthcare's cost has changed profoundly. So we need to think of innovation about how we actually address that cost, and we do it for those who are not otherwise going to get access. And I think that brings us on to tonight's panel, which is on non-communicable diseases. The cancer numbers are not good for many of the countries that we're focused on, the low middle income countries. We don't have necessarily good statistics, but we think 20 million cases in a year, 10 million, 11 million deaths from cancers. But this is in the African region, but we don't have good data. If we think about autoimmune diseases, there was a big study that was published recently from the UK where they looked at 22 million people over a 10-year period, and they saw a trend of an increase in the numbers of autoimmune diseases, things like multiple sclerosis and Sjogren's and myasthenia gravis, and a whole range of autoimmune diseases that you could see are now increasing in numbers as well. And of course, lifestyle, and we can mix autoimmune and lifestyle with things like diabetes, obesity, cardiovascular disease being one of the biggest killers. And we can't detach all of that from the work that's already being done. Because we also know that, for example, people living with HIV, as they get older, also have higher rates of non-communicable diseases. So we are sort of seeing epidemic layering upon on itself. And so this is why the NCDs are going to become a hugely important area, and the drugs that are required, and including things like obesity. Because although obesity is seen as an affluent, I've been struck walking around London in the last 2 days that I see many, many, many more obese people in South Africa than I see walking around the streets of London. And that is because obesity is becoming a disease of poverty and poor nutrition. So with that, I would like to say welcome to everyone. It's lovely to see you all, and well done for getting here. And I'd like to hand over to the panel, and we're going to hand over straight away, and it's going to be, I'm going to introduce the leader of the panel, who's Paul Nuki, who's the senior editor at the Telegraph for Global Health Security and Campaigns. Please, I'm going to hand over to you. Thank you very much.
And thank you very much for coming along. I want to try and make this interactive as far as I can. So if you've got questions, if you've got urgent questions as we go along, wave your hand about. And otherwise, we'll give 10, 15 minutes at the end for questions, which I'm sure can roll on. So, firstly, let me introduce the panel. Firstly, in the middle, Dr. Baiden, all the way from Ghana. Have I pronounced it right?
Yeah.
Baden. Sorry. So Dr. Baden is a pharmacist, and she is the Deputy CEO of Ghana's National Health Insurance Authority. And I think really runs the authority, is what I think. She served 2 decades, both in public and private roles in healthcare. She focuses on management, supply chain, and importantly for tonight's discussion, procurement. She's a chartered management consultant, chartered professional administrator, and has served on many boards, including the Pharmaceutical Society of Ghana and the Chartered Institute of Administration and Management Consultants, where she's a fellow. So thank you very much for coming on tonight. Next to me is Dr. Cary Adams.
Correct.
I've got that one right. Cary instead of Cary. Cary is CEO of the Union for International Cancer Control. He spearheads a coalition of over 1,000 member organizations across 170 countries, which is focused on reducing the burden of cancer worldwide. He has a long history tackling non-communicable diseases, served 2 terms as chair of the board of the NCD Alliance. And if you want a bit of Christmas pantomime fun, he was also once a banker.
Yeah, it's true.
So he knows about money.
Always a banker.
Always a banker. And at the end there, Dr. Mukul, Bhola, 2 decades of experience in all sorts of humanitarian response, including disaster recovery, resource mobilization, and more recently communicable diseases, non-communicable diseases. He's director of the Division of NCD's Digital Health and Capacity Building at the United Nations Institute for Training and Research. He has launched the Defeat-NCD's partnership, which works with health systems to prioritize action against NCDs around the world. Mukul is also a member of the Indian Red Cross.
Volunteer.
A volunteer, okay. So, I'm going to give each of them 5 minutes to tell us a little bit about themselves and their fight against NCDs. It's in the context of infectious disease, which has grabbed all the headlines for the last decade or more, to good effect. The big 3, AIDS, malaria, tuberculosis, we've had a huge impact on all of those over the last couple of decades. I know some are now leveling off a bit. But these guys are going to tell us a bit about strategies to do that with non-communicable disease, which are rising up really in their place as the priority. So first, who would like to go first? Dr. Baiden?
All right. Thank you very much. You didn't want to pronounce Ya wrongly again. Is Ya?
You caught me out, yep.
Anyway, thank you very much. And it's a privilege and an honor to be part of this dialogue because it's a very important topic. Global access to healthcare, what cancer and diabetes can learn from HIV and malaria. I will say that it's been some years now since I joined the National Health Insurance Authority, but then there has been a lot of discussions concerning NCDs. We know that about 86% of those suffering from the non-communicable diseases are mainly in the lower and middle income countries, for which Ghana is part of it. And in the past 20 years, if you'd remember, it was rare to have constant supplies for medicines for malaria and HIV. But in the last few years, with the combined efforts of, I would say, donors, health organizations, many people have now had access to products either for treatment, for prevention. And so with infectious diseases, we've done so much work on it. But then at the National Health Insurance, we are keenly attuned to the fact that there are multifaceted challenges that NCDs bring on board. As National Health Insurance, we are a social health insurance scheme that was birthed in 2003, so we are 20 years this year. And we started with 170 offices across the country. We have 16 regions. We also have 4,300 credentialed facilities who provide health care to our members. And hitherto, most of our members would have gone to our offices just to get themselves registered or have their cards renewed. But then in 2018, we had what we call the short code *929#. And so in the comfort of your home or in your office, you could renew your card, and so you don't have to walk and then also get yourself stuck in traffic, or that's going to also affect productivity. But then years after, we also noticed that we were hammering more on manual claims, so we needed to do a lot by digitizing our claims. And so now we have about 90% of our claims that have been digitized. And looking at all these figures coming from our claims directorate, we noticed that a lot of these claims were coming from NCDs. And so what is the problem? So it looks as if we've got to do a lot when it comes to NCDs. But what are some of the challenges that have come to our notice? The challenges in securing some products for these NCDs have been limited access to affordable medicines. If we do not have affordable medication, what happens is that there's a financial burden on the members of our scheme. Apart from that, it also increases the financial risk to our members as well. Again, we also noticed that limited access to healthcare infrastructure has been a bane, because if we do not have enough clinics, we do not have enough hospitals, we do not have enough distribution networks to make sure that we have these products for NCDs, then a lot more will have difficulty in assessing quality of care. Again, we also noticed that our health force, the capacity was dwindling because of brain drain. A lot of our doctors, our pharmacists and nurses were going outside the country, and so those who could help in the prevention, treatment, and patient management were not around. And so this has also been a challenge in securing some of these medications for the non-communicable diseases. Early detection has also been a problem because we don't have real thought-out structures for screening and then promotions, because it also needs some investments into making sure that we have a nationwide scheme for screening. And we also know very well that early detection would not lead to end-stage NCD cases. Again, we also notice that the dual burden of diseases. In Ghana, we have the communicable diseases and the non-communicable diseases. But a lot of effort was going into the communicable diseases to the neglect of the non-communicable diseases, and so we had to grapple with all these. Again, the global health disparities also is a factor for where most African countries are having difficulty in actually negotiating for lower prices for pharmaceutical products without compromising quality. Another thing I would also want to talk about is the socio-economic factors. Poverty has played a role. Health illiteracy is also part, and because of that, people have not had access to products to help them with their NCDs. But then some of the, I would say, interventions and strategies we have put in place is to make sure that most of these medications are produced in Ghana. The government of Ghana actually gave tax holidays to pharma companies in Ghana, also gave them huge discounts, and so most of these NCD products are being produced in Ghana. Some have moved from other countries to the enclave where we have this tax haven. Another thing that has been done, which is also I think very important to mention, is the telemedicine. Even though we haven't had so many years experience on it, it has helped very well because those in peri-urban areas and then in rural areas have had some education about their disease states, and because of that, it is really improving the numbers when it comes to the curative measures we are putting in place. Again, the workforce. There's a very big effort by the present government to make sure that we train a lot of our medics. And so we have postgraduate school for doctors, pharmacists, nurses, and we want to make sure that people are trained in detecting, in diagnosing and treating, and patient management of NCDs. In fact, with the infrastructure, what we have also done as the government is that we have what we call the Agenda 111, making sure that we have 111 district hospitals and regional hospitals across the country, such that there will be geographical access to everyone who needs to visit hospitals. Again, we have public awareness programs that have been initiated, and the Ministry of Health, which is the mother ministry, is making sure that all the policies are cascaded to the agencies. We are one of the 26 agencies. And the dual burden of these diseases, I think what has happened is that there's a coordinated effort in making sure that policies of communicable diseases are aligned to make sure that we do not neglect that of the non-communicable diseases. With the health disparities when it comes to the global health issues I talked earlier on, the government of Ghana is engaging development partners to make sure that we can have fair pricing across board in African countries, because pricing has been a very big issue when it comes to assessing quality products. Again, poverty alleviation programs have been birthed because we have what we call livelihood empowerment adjustment programs for those who are poor, to make sure that they have access to health care. And they address one of these main causes of our health disparities. And so literacy in the communities on some non-communicable disease and other disease states have been intensified. And so that's what I would want to talk about as challenges, and then some efforts in making sure that we handle these issues very well. But then...
Okay. Let me break it there.
Okay.
And let's go on to Dr. Adams. A brief overview of your view of cancer treatment around the world. I remember going to a hospital in Uganda, and I'd never seen cancers before, but in Uganda you really see cancers because they're treated so late.
Yeah, before I go down to the specifics of countries, and perhaps I can take a higher view on where we are overall, because this is a long-term game.
Yeah.
Okay, we can't resolve anything within a short period of time. It takes time. And so I think if we look back in the last 15, 20 years, we have seen a shift significantly globally away from the communicable diseases as a global issue. I mean, the MDGs were premised on addressing the communicable diseases, and it wasn't until 2011 that we actually got a high-level meeting on NCDs and a subsequent global action plan with targets for countries around the world on addressing the key component parts which either lead to NCDs or need to be treated for NCDs. So we've seen a shift, right? That's happened. We've had, I think, 3 NCD high-level meetings now. We've got a global action plan. We've got refreshed what they call the Appendix 3, which are the best buy recommendations from WHO. The essential medicines list is constantly updated. It was not updated prior to 2016-17. Now it's more up to date. So a lot of the component parts at the global level have been put in place. The question is, has that trickled down into national action? And you've heard great action here, and that's not untypical of many of the countries I hear. Although they lack the resources, lack the funding, lack the medicines, it's too expensive. All those component parts are very, very challenging for most countries, certainly lower middle income countries. But if you look at the progress in terms of national cancer control plans, the progress in terms of national NCD plans, we have over the last 10 years seen more and more robust and funded plans put in place country by country. And that's a success, because if governments don't buy into this, then innovative financing and other things are not going to work. All right? So we have got more countries around the world who believe in the NCDs being a major health issue and require specific attention, funding, and support from the global international organizations like my own, as well as others. In regard to cancer specifically, we are seeing progress in terms of the implementation of cancer control plans, but the progress tends to be on the easier components. So on prevention, tobacco control, all right? Things that are important to the whole of the NCD community, very important. In terms of screening, some progress. But when you get down to the treatment end of the spectrum, in terms of true cancer control, not very good progress in low and middle income countries. And that's where 70% of deaths are, and that's where 70% of the growth will be in the future. So the solutions that we're seeing in that part of the world at the moment are not robust. There's a cost impact of investing in radiotherapy, surgery, pathology, diagnostics, and the medicines. There's the core skill gap in terms of that support. But I do believe we're at a point now, we're getting past COVID, where we can actually work closer with those countries, and through the availability of remote training, remote diagnostics, remote AI to support all of those core infrastructures, there is a potential we could leapfrog a lot of the challenges that we see today. But we still need core infrastructure funded and put in place. Okay. So I see progress, but it's a long-term game. We're not going to solve this in 2 to 3 years.
Okay. Mukul, your overview.
Thanks. First, let me just thank Michael for the kind invitation and the entire MedAccess team for all the support in preparation of this event. Really glad to be here in London with you. In terms of overview, I think my panelists have given a very good overview. I think we're coming up to 40 years of HIV having really got going. And I think it's really the struggle of individual people that actually pushed for some of the trade-related IP agreements, South Africa and India in terms of having a push for some of those agreements to get the prices down to 99% of what they were. I think a real inspiration, and we should really keep that in the back of our minds, that it is possible to make progress on the fight against NCDs. I absolutely agree on Cary's point that it's not a short-term sprint, it's a marathon. And I think in identifying partners that we collaborate with, both in terms of program countries, but also in terms of donors and international organizations, as well as domestic organizations, we have to have a specific focus on those who've got the will to move beyond annual funding cycles and really have the willpower to go the long haul in some of these very challenging environments. In terms of numbers, I mean, HIV/AIDS, we had 86 million people infected, I think, over the last living with HIV, and I think 40 million deaths. So the annual NCD death toll of 41 million is really the biggest challenge that humanity has seen. It's the biggest killer.
Is that the premature number as well?
The
it's below 70, is that below 70?
For NCDs, the premature number is 17 million deaths per year. 41 million is overall deaths. And 86% of the premature deaths are in low and middle income countries. So this really makes it more than a health issue, a equity issue, as Helen mentioned, and the work that MedAccess is doing, but also a human rights issue. I think funding hasn't really trickled down. Michael, what, 1-2% of overall health spend goes towards NCDs over the last 20 years? So progress has been made in terms of the international commitments, and I think, Cary, your leadership on NCD Alliance,
Well, actually,
the
it's
advocacy.
Katie Dane. There's Katie Dane's over there.
Katie
Anyone doesn't
Dane.
know Katie Dane. Katie Dane's
Hi,
the
Katie.
Executive Director of NCDA, so she'll take your questions. Okay.
It's amazing. Without Katie's work and NCD Alliance's work in terms of advocacy, we wouldn't be where we are. So huge kudos to you there. But I think that the real challenges that I see, the increasing out-of-pocket expenditure. So the solution isn't in international aid funding, which is very small. Countries have been left to sort of deal with it by themselves, and households in particular, particularly those in rural areas, particularly the elderly, those with young children. And I think one of the big challenges is also the health coverage, health service coverage, which has sort of been stagnant since 2015. The number of, in fact, the only rise in health service coverage has been in the infectious diseases, about 7% per year. So I think, what does that draw us to? The need for greater data in some of these countries is very important. That's a role where international organizations and local alliances can play a big supporting role, because that's a prerequisite if we're going to talk about anything fancy like innovative financing. Helen mentioned it, that sometimes it's difficult to get to do a 3-minute elevator speech on innovative financing. Imagine that in London with all the resources that we have. Imagine how scared people must be in a receiving country when we talk about some of these trillions of dollars required in terms of investment cases and structuring such complicated mechanisms. They take years to structure. The experience with some of them I know some examples with the ICRC. First, you need scale in terms of the market size to be able to launch some of these products. B, I think MedAccess has done it right, because from what I've read, you've done it, you've basically structured every single agreement on a case-by-case basis, really understanding all the needs and interests of every single stakeholder. Unless you do that, and that's very painful, unsexy work, unless you do that, it requires building trust at the country level. We're not going to get anywhere. You need that mutual benefit understanding to be able to design some of these products.
Okay, so could I ask there, should we be treating NCDs as a thing in itself, or should we be breaking it down to look at the individual diseases? Is it a good catch-all? I don't know if the panel's got views on that.
I can start on that, because I've been right in the middle of that since day one, because the UIC was a founding member of the NCD Alliance. And I must admit, when I went to the cancer community saying we're going to form an NCD Alliance with diabetes, heart disease and lung disease, a lot of the oncologists were saying, well, why do we want to work with diabetes? No one dies of that. What's the problem? We're far more difficult and complicated. There was a real pushback, but nonetheless, we got through that. And I think there's real value in working together on some broader NCD common ground areas, all the risk factors, for example, the investment in UHC, improving primary health care, even palliative care. AMR, another good one. Let's invest in AMR collectively. There are so many things where there are common ground, and we do have to work together. We have to be consolidated at global, regional, and national advocacy.
But is there a but?
The but is when you get into treatment. I mean, there's no doubt about it. If you look at the way in which you treat diabetes or you treat heart disease compared to where you treat cancer, cancer is a little bit more complicated, not least because every indication needs a different approach. You've got radiotherapy, surgery, and you've also got chemotherapy and associated drugs, antibiotics, for example. So you've got clear areas of difference. And that's where I think it's important that we recognise those differences and we don't cause like a cantankerous argument between the various groups. We say that a UHC needs to cover all the population, or as much of the population as possible, for the diseases which are inherent in that country, going back to a national NCD plan. And if cancer is a growing burden, particularly breast cancer or cervical cancer, whatever it may be, then there needs to be an investment in that, and you have to apply the appropriate treatment protocols. So I think there's lots of common areas, but there are areas where you do need to make it very clear there are specific treatment approaches which are to that disease, whether it be a breast cancer, a prostate cancer, diabetes, or other NCDs. Okay. And that's the key difference.
Yeah.
Okay.
How would you see it? And I'm going to say that from an outsider's perspective, if I were to ask people to donate and contribute to tackling NCDs, they glaze over and say, look, I'm going to do malaria or HIV or something I know about.
Anyway.
And you're a journalist.
I'm a journalist.
What I'll say is, does bundling them under one term hinder us from having strategies at attacking or working at every disease state? No, because from hindsight, what we have noticed is that the approaches that were used in tackling HIV, tackling malaria, actually gave us strategies to handle each disease state. And I think we could do the same when it comes to non-communicable diseases. But then what we should not also forget is that there are some certain overarching issues that are common across board for all NCDs. For instance, lifestyle changes or factors. We have some risk reduction strategies, and we have some promotional and healthy behaviors we need to work towards it. And so there are some collaborative efforts that need to be put on board so that we can crucially address these issues that have shared concerns. Again, what we have noticed that across board, maybe in Ghana, that's what I'll say, NCDs are fairly entrenched when it comes to claims payment. For the first 10 disease states, NCDs are actually giving us high cost in terms of payments to our credentialed facilities. And so, on one hand, in Ghana, what we want to do is I want to acknowledge the need for specialized attention to these individual NCDs. But then again, on the other hand, we also want to bring this collaborative effect in making sure that these overarching challenges are dealt with such that these NCDs can be treated and treated well. And NHI has been engaging stakeholders, be them local or international, in making sure that we acknowledge the common risk factors that underline all these NCDs. So some of our efforts have been to actually work in tandem with some health organizations, some educational facilities. For instance, we have an alliance with the University of Ghana, that is a premier university, their business school. They have been giving us some information about the claims that we have actually educated for some years now. And it points out that in certain districts in regions in Ghana, there are some behavioral issues we need to tackle if we need to attack NCDs head on. And so it is good for us to know that it is not a dichotomy, but it's a dynamic spectrum in making sure that we tackle these NCDs head on. And so I would say that we can adopt both approaches, looking at the NCDs, the specific areas we need to look at in terms of their prevention, their treatment and management. But then because of these overarching issues as well, we could also look at having collective efforts in making sure that these NCDs are handled head on. That is my contribution.
Thank you very much. Mukul, you've got a view?
Yeah, absolutely. I think from a communication point of view, I agree with you. It's easier to run campaigns on specific. It's just a mouthful also sometimes we're all converted people, but I think it's quite difficult for others. I think in our experience, both in Rwanda with the Defeat-NCD partnership and UNITAR, and in Myanmar and in Gambia, where we developed with the country costed action plans. So countries have got strategies and plans, and they do very well, and a lot of them have been increasing. But actually costing interventions, documenting what the out-of-pocket expenditure, bringing that data to help some of those innovative financing mechanisms that are being developed. I think we found that using the term NCD and bringing sort of everybody into that tent, the diverse range of actors. I think in Rwanda we had 70 different stakeholders that we consulted over the course of the year, government, civil society, private sector, academia. I think that was very useful. And it also helped bringing in particularly the cancer folks, also in that mental health into that equation. In fact, Rwanda, they're very keen in terms of getting oncology drugs, I think very proud nation otherwise. So I think that really helped.
And just tell me a little bit, while I've got you there, on the division between infectious disease and NCDs. So we talked before this discussion a little bit about HPV. Where is that falling? Is that an infectious disease?
It's an infectious disease.
Or that's it?
But it causes 95% of cervical cancers.
Yep.
That's where it becomes merged.
Yeah.
Okay, so for example, we work very closely with WHO over the last 3 years to get the cervical cancer elimination initiative kicked off, with member states buying into that. But that braces everything. That's about HPV vaccinations for young girls. It's about screening on a regular basis to identify lesions before they become cervical cancer, and then treatment associated with that, and then the treatment. And all three components are put in place at the levels they're suggesting, which I think is 80, 70, 80, is it? Something like that, 80%, 70%, 80%. So 80% of the girls received their HPV vaccine when they were 10, 11, 12. You can foresee that we could eliminate a cancer.
Yeah.
A cancer could be eliminated over time. And I think Sweden are looking to get it to eliminate it in the next 5 years, I think it is.
Yeah.
So there is a crossover, and there's a lot of crossovers. You mentioned HIV/AIDS. Women with HIV/AIDS are far more likely to get cervical cancer.
Yep. Far
Far more likely. So in some ways, the NCD/CD debate becomes a bit immaterial. It's about caring for the health of the population, and the government not putting 2% of GDP into health, but putting 8% or 9%. And you see countries that invest at that level, do you know what? They become wealthier over time because they have a healthier population. So I think there's that broader issue is important. I don't really enjoy meetings where we do go in and talk about NCDs versus CDs. That's why UHC is important, because it brings it together. And I think governments buy into the concept of UHC, but as long as they keep cancer, the more expensive one, on the table, because UHC can become, somewhat, I'll choose what bits of UHC I want. No, cancer's still got to be there.
Okay. So moving on a little bit then, for Cary and Mukul, pricing. So low and middle income countries have a bad deal on a lot of medicine, right? It can be much more expensive, and it can simply be hard to get or impossible to get. Can you tell us a little bit about how your organisations have been involved in trying to improve that with data and information generally?
Would you like to?
Well, yeah, so in terms of data, I think helping countries identify what they're actually spending as a country is a very important first step. And we did that where we had a 370 million odd costed action plan over 5 years in Rwanda, 35 million costed action plan in Gambia in terms of how to help the country reduce the pre-mortalities by 1/3 from NCDs. I think pricing is perhaps the easiest piece. We were talking about this, Cary, earlier. I think small countries have less purchasing power. So, the cost of a medicine is actually a commercial decision by a supplier, whether to supply it or not. And yeah, it's very opaque in terms of pricing. But all my discussions with industry have said, yeah, if you can give us a very accurate forecast of demand, then we'll reduce the prices by up to 30% in some of these cases. So I think getting that right, and that's the challenge, lack of data, both for screening and diagnosis, but also for continuous monitoring. And that also comes back to the innovative financing piece, because we're going to need that continuous data for the outcome measurement as well, right? So I think in heavily investing in collecting that information is something that governments we need to be supporting with in order to get some of those pricing down. We've attempted this in the Defeat-NCD partnership in terms of trying to pool procurement. Particularly, we focused on HPV vaccination in India, in 3 states, in Madhya Pradesh, Jharkhand, and Goa. Unfortunately, India, for the last 10 years or so, didn't really launch a nationwide campaign on HPV, causing millions of women to die, actually. But I think kudos to the government that they've actually done this over the last few months, launched a nationwide campaign. There are new industry players like Serum Institute, which have previously been heavily involved in the COVID vaccine, that are actually doing domestic supply. So I think that'll bring down the cost of HPV treatment significantly. So very excited to be supporting the government in a small way in India.
Okay, so Cary, you're dealing with some of the most expensive drugs for cancer treatments. How are you finding that around the world in lower income countries?
Well, the new ones are expensive, okay? But on the essential medicines list, WHO, the majority of them are generics, been around for 20 years.
Right.
And they're still not available. 50% not available in low and middle income countries. So the pricing challenge is a challenge of many colours. You know, if I take...
Why aren't they available?
Well, there's 1,000 reasons. I mean, this is one of the reasons we've set up the Atom Coalition, is to address all of those barriers which are inherent in the system, the business model to get a medicine from a company into a patient in a low middle income country. And that varies, like, there's no pathology and diagnostics. What's the point?
Right.
Everyone presents at stage 3, 4. What's the point? Okay. There's no method of being assured quality all the way through. We don't want to do voluntary licenses because we're not sure about voluntary licenses. You know, these are our target countries where we think there's a potential for the future, but we don't want to go into those countries because we don't want to support any adverse reactions. There's hundreds of reasons. The government doesn't have enough money. You know, there aren't enough oncologists. There's no radiotherapy machines. So there's 100 reasons, but we need to work collectively to address those reasons. The reason I say price is I think it's an issue, don't get me wrong, but it's not the issue. If I look at, you mentioned the cancer deaths when you spoke earlier. 20 million cases and 10 million people die of cancer. 6 million die in pain because there are no opioids, there's no morphine. Can you imagine those of you who've seen been close to a relative who's died of cancer not having morphine? I mean, it's incredible. People get sent out of the hospital because they're too noisy, because they're screaming. You know, this is the reality. There's no opioids in those countries. So and that's really cheap as a medicine. It's not chemotherapy, it's really cheap. So I think pricing is one of the issues, but it's the market dynamics. It's creating those markets. And what Mukul was saying earlier, you know, what we're trying to do with the Atom Coalition is break down many arguments. And one of those is there isn't enough big enough market. It's too difficult to do registration here, registration here, registration. Multiple registrations takes time, effort, energy. It's difficult. It's expensive. So can we do collective registration across multiple countries? And can we give them a volume which makes sense for them to produce a generic or a biosimilar, as opposed to relying on donation models, which we do at the moment? So I think there's a whole series of things that we can do which address some of the component problems, and then pricing then becomes maybe a commercial decision, or it's a CSR decision based on what the company wants to do, or the volume that can be insured and then guaranteed by the likes of MedAccess. So we've got to be really clever in the way we address this problem. We can't point the finger at the pharma companies and say, it's your fault. It's not their fault. It's a solution that we have to find collectively.
Okay. Yay. Tell us a little bit about dealing with these pharma companies directly.
I think Michael is all ears because when we met in New York, he was interested in listening to what other pharma companies have done in Ghana. We would want to speak about some interventions that, as a nation, we've been able to track. Negotiating with these pharma companies is complex yet, but you need to engage them, and especially so when there are high prices and then you can't also get the products on the market. Cary also said so. It's about the National Health Insurance having strategic negotiations and discussions with those who are ready to come on board to make sure that these non-communicable diseases are actually tackled health. One of the successful negotiations that we have had is with Rees. What happened was that we needed hepcidin on our medicines list. We also go through the process of having medicines on the essential medicines list before it comes to the National Health Insurance medicines list. And what happened was that they gave us 70% off the cost of Herceptin, and so we are paying $400 on our health insurance scheme, and they are taking 70%. That's for Ghana, but I know in Nigeria it's a parity 50-50%. So it all depends on how you are able to negotiate and then the volumes. Hitherto, only 10 women would have finished 12 cycles, but now 800 plus women have had opportunity to finish those cycles. Again, what we have also noticed is that they have gone even beyond these drugs. They are giving support to the Ministry of Health, making sure that they are training oncology doctors, that is clinicians, pharmacists, nurses. What they have also done in the past and what they are continuing to do is that they have increased the number of cancer sites for treatment from 2 to 5. And so this is actually opening access and reducing mortality rate.
So overall, would you characterize the relationship between Ghana and these big pharma companies as good, or is it tense? How do you see it?
It's the beginning.
As your lawyer, can I advise you?
We need an honest answer.
I ain't going to say anything bad or good, but then it's the beginning, and we've had some successes that we have chalked. There are some difficulties, but we are hoping that we'll be able to surmount some of these difficulties. But at the end of the day, what do you hope to achieve? You want to make sure that the one that needs it, the citizen of the nation, has access to these products, and that is what we are working towards doing. Of course, the government of Ghana also is making sure that we have pharma companies within Ghana who are being supported to produce some of these medications. And so it's not only pharma companies coming from outside, but those within are also being supported, so that at the end of it all, we can be the hub we want to be in West Africa, because that is what the government wants to do, make sure that we are becoming the pharma hub in West Africa. We can produce medicines for ourselves and then for our neighbors as well. So we've gone a long way.
Okay. So Cary, one for you. Gavi, the Global Fund, have made huge differences to collective procurement for infectious disease. Should we be looking at the same for various NCDs?
No.
No.
That was a closed question.
The money's not there.
No,
the money's not there?
This has come on the table many, many times and been discussed at the NCDA board many times. I work very closely with the missions in Geneva. There is no appetite from any member state to establish an NCD Global Fund. And zero. The opportunities are to work with Global Fund and Gavi. I mean, for example, Gavi adopted HPV in some ways because UIC said you've got to do HPV because of cervical cancer. You've got to do hepatitis B because of liver cancer. So, I think we can work and influence with those global funds, but post-pandemic now, chances of getting a global fund for NCDs, zero. And I don't know if anyone disagrees with me, but I really can't see that.
What do people in the audience think about that?
Anyone want to take a bet? No.
Could you imagine a fund for breast
there
cancer?
is a silver lining. There is a silver lining. I think that there is scope to get funds together for some core infrastructure. And I'm very interested at the moment pursuing lines with companies about establishing a fund for pathology and diagnostics capability in low middle income countries. And that will be an investment which will be of value to communicable, non-communicable. It would break down one of those barriers of entry for essential meds to come in, because we'd know who's got what. And so I think that would be a good fund to establish, to put core infrastructure in place that would benefit every sector. Okay, so that's where I think there's mileage, but I'm afraid I can't see. I mean, the only one that exists at the moment is really the St Jude's funding for childhood cancer medicines, which is being done with WHO and being run by UNICEF, which I think is a very specific, targeted cancer, and quite rightly, because you've got 80% cure rate in high-income countries and 20% in low and middle-income countries, and the drug can cure. So that makes sense, okay? But it's not a massive fund, and St Jude aren't going to keep pumping cash into it at the level they are at the moment, I don't believe. So we need to crowd in some other investments there.
So, so for infrastructure, for universal health, but not specifically for NCD.
Just to add to what Cary said, quite recently we added 4 childhood cancers to our benefit package. That's the Wolff's tumor, retinoblastoma, AL, and then Becky's lymphoma. And I must tell you that it has brought smiles to the faces of parents, because hitherto we would have lost these children. So 70% of these cancers for children have been tackled head on, and it's still Roche that is helping. We have other companies like Novartis that has come on board also to bring hydroxyurea for those suffering from sickle cell. And so there have been a lot of collaboratives, and we think that when we continue to strengthen these, it will help. But then, when it comes to Africa, we have this fluctuation in, I would say, pricing due to interest rates and the rest. So that has been a bane, but then we are navigating through it, and we hope that when we have these companies coming on board for us to explain to them that at the end of it all, we are saving lives, they actually do not look at the profits alone. They also look at making sure that they make a mark in the countries that they have actually gone to.
Well, certainly the power of childhood cancers and health generally to engage people more broadly in health is incredible, right? You see Great Ormond Street here historically has been really powerful on that. So Mukul, looking at it from the other way up, are there local initiatives that you've seen that should be scaled and we should be shouting about?
There are a few. I'd just like to come back to a point that my panelists made about, I was just thinking, countries negotiating with pharma companies and industry, sometimes it's difficult because of their own procurement processes. It's seen as a commercial, relationship. So why not try and build on the successes of Stop TB partnerships, pooled procurement mechanism? We're supporting Cary with the Atom Coalition in terms of making our procurement agent available. Why not try and leverage on some of those initiatives? Because what'll happen is that'll give confidence to the suppliers, manufacturers, because in some cases they lose out because of corruption issues in some countries. So it'll give a higher level of confidence, which will actually contribute to bringing the prices down if that's one of the concerns. It'll leverage on the tools that are available already in the international architecture. And I was just sitting on the plane while stuck at the airport in Geneva, and I was reading Michael, your former colleague's blog on this. Why not reorientate some of the, given the progress we've made on HIV/AIDS, why don't reorientate some of that work that UNAIDS is doing and others doing into tackling this? You won't get the billions of dollars of replenishment, because I absolutely agree there's no appetite. We've consulted all the donor countries and others. But I think Global Fund is doing that a bit. They've got underutilized money, which can and is being channeled in diagnostics for NCDs at the moment.
Yeah.
So I think there are opportunities to coming back to your other question on
scaling up.
Scaling up, yeah. A couple of good examples. I think lung cancer, 20% of of people living with lung cancer actually come at stage, less than 20% at stage 1, right? When their survival, 5-year survival rates are about 68 to 90 something percent, whereas 80% come at stage 4, where the survival rates, 5-year survival rates are less than 10%. There's one initiative that we've been looking at, Cure AI, which is actually used to work in the area of infectious diseases, both TB as well as COVID. They're scaling up hugely. They've taken the highly expensive cost of CT scans, which in low and middle income countries are completely out of the reach of people, and actually brought chest x-rays at more affordable prices that can actually detect lung abnormalities and actually make the referral much easier. So I think that's a concrete area that's expanding hugely.
So AI does promise to revolutionize.
Absolutely. In Ghana, one of the, I don't know what your experience is, but great young man who's leading M-Pharma, which is essentially and he's expanded to Nigeria and a few other countries, huge, very successful model. Given the shortage of physicians in the country, as distinguished panelist just was mentioning, is using telemedicine to actually bring in a remote physician into the community pharmacy. Again, we're talking about trust, where trust in your local community pharmacy is much higher than anywhere else, and the cost of actually traveling to a healthcare facility is. So he's actually hit the, completely giving even government, supplementing, complementing their efforts by bringing a nurse, a social worker, a community worker inside the pharmacy itself, and telemedicine physician to actually improve access to care. I think huge. So again, promoting entrepreneurship, because we're not going to do this. How are we going to solve this? Some price reductions in terms of service delivery, and in that we need health entrepreneurs and innovators. Some price efficiencies in terms of pooled procurement and testing, as Cary mentioned. Some aid funding, because that is catalytic. And then helping structure some of these innovative financing, non-traditional financing mechanisms, informed with the evidence and the data, and backed by people like MedAccess and others to provide some of those voluntary guarantees, and bridge financing, which we haven't talked about, but that's a key area. Some countries even have the money to do the procurement themselves, but they don't have the financing available to close it within the period. Yeah.
Okay, let's have some questions from the audience. Open it up a bit. So, who's got a question? There must be one of you. God, blimey. All right, in the front row.
No, I just wondered, one of the things that's happening, and you've referred to it with cervical cancer, is targets. And, we've got targets for all sorts of things now. We've got both elimination and eradication targets. We've got 95, 95, 95s for HIV, and we've got the 90, 70, 90 for cervical cancer. We've got loads of targets. Are targets useful in this field? And if so, what would we go for something, we've done it for cervical cancer, would we go for a big cancer like breast cancer, which does have, a much more kind of, if you like, popular leverage than perhaps other cancers as a starting point?
You're talking to a man who did economics, computing and stats at university, an MBA, and was a banker for 24 years, and you're asking me whether targets are useful. Yes, they're useful. They are useful. They're useful because for me, they're an indication we're taking it seriously. Now, whether we hit that target or not, and we won't hit the 2025 targets for NCDs, we know that. COVID, pandemic, they were a bit aspirational as well, but those 9 targets, we won't get there. but they'll be pushed back to 2030 or 2035. But they are something that we, as a community on this earth, are trying to achieve. And that is a great message to the younger generation that we're taking it seriously, whether that be HIV, whether that be breast cancer, I don't care. I like targets, because from that, a whole series of action plans flow, accountability flows, and we as advocates can look someone in the eye and say, where are you on your target? And there's no wriggling around, no weasel words, oh yeah, we've got an NCD plan. No, how are you going to achieve that 30% reduction in tobacco use? What are you doing? So I believe in targets. They can also use them to measure country A versus country B. WHO doesn't like doing that, but we do. We like seeing who's performing well, who's performing badly, because that motivates the local advocates to talk to their government and say, why this not doing brilliantly and we're not? You know, what are they doing? And it encourages learning, exchange of ideas and views. So I'm a great believer in targets.
Okay, we've got a yes on targets. Anyone else on targets? Or
Agreed, yeah, absolutely. Targets, we all know that where all of the countries are off the targets to meet the SDG targets, but they're still great unifier in some senses, and also great for accountability.
Okay.
But each country is specific. So whereas we're going on HPV, because that was the only, after a lot of analysis, we saw that if you're going to make a dent in India in cancer, I think that's an area that we saw that we wanted to focus on, but it might be breast cancer in another context.
One of the lessons, I think, in the West with a lot of non-communicable disease, diabetes in particular, I'm thinking about, and other vascular diseases, one of the huge mistakes we've made in the West is to allow our lifestyles and the consumption of junk foods and tobacco and alcohol to get so far out of control. I wondered if you thought that lower and middle income countries may be actually better positioned in some ways to take advantage of the lessons, the poor experience in the West.
Some years ago, when we didn't have this big food chains in Ghana, our NCD rates or mortality rates were quite low. But we are also enjoying, because we're on camera, I don't want to mention names. We have all these big companies in Ghana, and cholesterol rates are going high up. People are dying of NCDs. And so there's this critical talk on why we still know that these lifestyle factors are contributing to the rise in NCDs and nobody's talking. We need to, I won't say name and shame, but then we need to let them know that what we are consuming is actually contributing to some of these risk factors we are talking about. So then you would also have to contribute towards making sure that we have preventive measures in place. When you take FDA, for instance, in Ghana, what they have done is that they have made sure that most companies who hitherto were not going according to the laws are punished severely, especially when it comes to tobacco control, alcohol consumption, because all these have bearings on NCDs. And when there are stringent measures put in place, it gives people the confidence that we are putting in pragmatic and collaborative efforts to make sure that we flush out NCDs where they shouldn't be. I mean, it's a concerted effort. I mean, both locally and internationally. We are doing all that we have to do as a country to make sure that we have big pharma companies coming on board. We are giving them infrastructure development. We are also giving them state-of-the-art facilities. R&D is also there. We are also boosting the morale of those who are coming in as staff or workers or skilled labor. But all this, when we do and we are still continuing to exhibit these bad behaviors, then it is like we have a leaking basket. We are just putting money in and out, because it's difficult now for a global fund to even support us. Ghana, as a lower middle income country, is now paying for its own vaccines.
Yeah.
But thank God we have a vaccine institute which was commissioned by our president this year. And so we want to make sure that we produce a lot of things ourselves, because during the COVID era, we didn't have that luxury. We had to produce a lot of the hand sanitizers, a lot of, if I'll say, the gloves, the masks by ourselves. And so it brought some entrepreneurial spirit into the fabric of the youth. But then if we do not maximize these gains, what will happen is that we wouldn't have learned any lessons from what we went through during the COVID, because with the COVID, it actually affected NCD attendance in hospitals. And when we look at our claims management processes, we notice that a lot didn't go to the hospitals for their diabetic care or their hypertensive care in 2021, 2022. And so we have a tall order in making sure that NCDs is actually tackled head on if we really want to make a case for the reduction of these non-communicable diseases in our lifestyle.
Okay. Questions. Look at them. They're all bouncing up.
That was a great tour d'horizon. Thank you very much. Really clear, obviously, marathon, not a sprint, complicated, lots of barriers, number of different NCDs, prevention, diagnostics, treatment. But making it relevant for MedAccess, could I ask each of the panelists, which disease area, which product would you want Michael and MedAccess to focus on first, where you think a big price reduction would have the biggest impact on the area?
Should we go down the line?
Quick answer, each of you.
I would love pathology and diagnostics, I said earlier, as a priority. And if we're able to incentivize the diagnostic companies that don't have a lot of space in their P&L, to be honest. They don't do a lot on CSR, because they haven't got a lot of money, and they're very cautious about where they go. If we're able to de-risk that investment across multiple countries, so we can put in the diagnostics and pathology for a core set of diseases, and I mean a core set, including CDs and NCDs, I think that would be a great opportunity for all of us to work together, because I think the companies would do it if they could see assured long-term volume and they could get some sort of guarantee. So that's a great place to work. On the medicines themselves, I'm not sure. We need to reflect on that, because that is very localized, dependent on what else is there and everything else. But pathology, I think, diagnostics, that would be a great place to start.
I think diagnosis is also a big area which is untapped in Ghana. A few have come on board, Abbott and Hologics and a few others. But then we could look into areas where we could bring more diagnostic companies to Ghana to make sure that we can have a seamless process where we tackle the patient from beginning to the end, instead of them moving out of the hospital to go to private facilities to get their labs checked out. But I think diabetes is an area where there are a lot of these drugs on board which MedEx can look at, which ones that can be registered in the country through the FDA, and then which marketing company can make sure that they can push for more volumes. Because at the end of the day, it's about access to quality basic healthcare. That is what we are looking to achieve as a country. And for NHIS, what we do is that we provide financial risk protection for quality basic healthcare. And so if the drug is affordable, we can get it at a cost-effective price. Why not? We'll put it on our NHS list, but then we need to go through a lot of processes to make sure that we have value for money.
Mukul?
Yeah, I think you've already identified them well, diabetes and cancers being the largest causes of mortality. And I'd be very interested if you focus on HPV, because I think they're huge. There's demand also, and there's huge price reductions that you could really play a role. But it will also depend on where you've got relationships, because every single deal, as you would have seen, is very tailored. So it depends which geographies you're looking at. You won't have any problems from the industry side, I don't think, in terms of getting agreements done. So I think. So
thank you for that question. Have we got one more question? I reckon we've got time for. Who's going to go? Go on, lady at the back there.
Thanks very much for the really interesting conversation. I'm Cecilia. Just wanting to go back to the conversation, Dr. Ya, that you raised around the brain drain in Ghana that we're seeing across the continent of Africa. And I'm of the Dr. Cary Adams school of thought that the distinction between NCDs and CDs is really not serving us. We learned a lot of lessons during the COVID-19 pandemic, adaptations in the HIV sector, where we're seeing community ARV groups coming together, but then a lot of discussions also around prevention adapted by the WHO. What is the place that you see in Ghana, or really just across the region, around innovative financing to ensure that community systems are seen as a critical component of the health system? We're talking about resources dwindling. What is the innovative financing around that piece?
For now, what I'll talk about is that with the social health insurance scheme, we have a structured financial system where we have 2.5 percentage points from our SNIT contributions. We have 2.5% from VAT. We also have donors also supporting us. We have the fund processing fees that are paid by members, and then premiums that are paid. So that is the structure which we are handling in the National Health Insurance Scheme. But then there have been talks with World Bank, with WHO on domestic resource mobilization. And we are looking at areas to make sure that it doesn't become a burden to our members, because we want to make sure that apart from the social health insurance scheme, if you want to opt to be a member of the private health insurance scheme, you're good to go, but then you should first be a member of the social health insurance scheme. And so for now, we haven't actually looked at areas where we could get some additional funding. But then we started talking about getting some other tax from tobacco, from sin tax, those who consuming a lot of sugar, and then road traffic accident levy. We are still in consultation with the Parliament of Ghana to look at where they could increase some percentages for us, so we could add it onto our, I would say, funding, because as it stands now, we are taking just less than $5 per person to be a member of the National Health Insurance Scheme. And in fact, 69% of people covered under the National Health Insurance do not pay any premium or processing fee that is below 18. We have above 70 not paying because they are pensioners. So I would say those in the non-formal are the ones paying these premiums and processing fees we are talking about. But a lot of discussions are going on to make sure that we could tap some more finances from the sin tax and from other areas where it could help the scheme to be sustainable, because people are asking us to add on to our benefit package. For instance, we have the men coming on board to tell us we should add prostate cancer. We said, you added the cervical cancer, why didn't you add the prostate cancer? Now they're telling us, oh, they would wish that we add mental health to it, even though we are handling all other disease states associated with mental health, because first we're having programs where we're handling these issues. So we have a lot of pressure as an insurance scheme to add on to our benefit package. But the sustainability is the issue. We need to go through actuarial models to find out whether adding on to is not going to collapse the system. That is why we need some financing elsewhere. Yep. And so these are talks that are being held, and we are hoping that something comes up so soon. Thank you.
So I hope that answers the question. The idea of the polluter paying is, I think, an important one, and one we should probably have introduced in the UK. It would make a big difference to health funding, I think. One more question. The gentleman down here, I think, wanted to ask something.
Thanks a lot. So NCDs is a relatively heterogeneous group of diseases, and I'm kind of curious, when you think of health policy, how you discriminate or how you prioritize amongst them when you're talking with policymakers. And I mean, do you think about it in terms of economics and dollars and qualities, or do you think about it in terms of equity with, like, where do you see the biggest gap between survival rates, or do you just sort of capitulate to politics and the emotional attractions of, like, focusing on child cancers, which, you know, are probably the easiest sell for funding. I'm kind of curious what your strategies are for funding this.
So from a cancer, I don't get involved in NCD negotiations. That's Katie. Okay, she can talk about that. When I talk to health ministers about cancer, the key things I'm looking for is that they have to invest in registries, first of all, and also diagnostics, so that they can pick up their cancer burden. And they should craft their National Cancer Control Plan around the specific burden in their own country. And therefore, they need to look at it with advice of WHO, etc. They're taking the best buys, and they look at the options available in terms of prevention, detection, treatment, and care. And they have to make decisions based on their own epidemiology and how they would justify an investment. Because each country will have a different perspective on why we'll invest in A as opposed to B. And it's not for me to say, well, you're wrong, you should do it this way. I want people like yourself to make the decision for their people based on good data and good information. So our drive is get good data information and get a national cancer control plan which meets the requirements of your country in the longer term. So it isn't as simple as doing, well, focus on the dailies or the cost-benefit analysis. It's a guidance. And as long as you can work with the country, because at the end of the day, they have to take ownership. They have to own that whole process of developing a national cancer control plan, because then it has legs. It's going to last. Just dropping here's a national cancer control plan for you, and we think you should do A, B, and C based on our analysis is not going to work. So it is quite bespoke, country by country. The best plans, in my opinion, are those that are written by the country, for the country, by the country.
But the guiding principle is one of burden.
Yeah, reducing burden over time. I mean, overall, if I look at, take Europe, only 2% of health spends on prevention. I don't think that makes sense. I mean, most of the best buys from WHO for NCDs are in prevention. You know, they're not in treatment and care or screening, they're in prevention. So one would expect there to be more spending on tobacco control, the issue of obesity, physical inactivity, alcohol use, etc., etc. But only 2%. It's all on this side. It goes back to what you're saying there. You're both encouraging pharma to come in with their medicines and radiotherapy, Varian Electa to come in, but at the same time, through the back door, you've got the international food producers coming in and they're making the situation worse. I mean, you know, what a terrible situation to be in. Yeah. So
Okay,
there's no one answer, I guess, is the answer.
All right. Well, look, thank you very much. I'm going to wrap up here, but Michael is going to come up, say a few words, and hopefully summarise a little bit for us. I was going to do it, but you're much better qualified.
It's my happy task just to say thank you, really. But I approach this topic, as with all of them, with great optimism, because my hope and vision that climate change and wars notwithstanding, that 50 years from now, we will have solved a lot of these problems. That's my fervent hope. And if we will have solved them in 50 years' time, we need to think about, well, where do we need to be in 10 years' time? And I think that this panel discussion has really helped me, anyway, to see the path forward and some of the paths emerging. I do remember in 1994, I spoke at Copenhagen at the UN Conference on Economic and Social Development. I was a lawyer back in those days, but I did speak on a panel about cancer. And I remember being yelled down by people in the room who said that it was a luxury to think about cancer when we had malaria and HIV. And it wasn't allowed, for a lot of communities, it wasn't allowed to talk about the subjects which were deemed to be too expensive as luxuries. And I think we've just come so far in that time. But there are a lot of complex challenges here. But I think this panel is really showing the way to some ways forward. But I also wanted to say thank you to those who supported this event tonight. The Foreign Commonwealth Development Office, who thought of the original idea of MedAccess and who's kind of stalwartly funded us throughout this journey. British International Investment, which is 75 years old this year, the world's oldest development finance institution, who has provided us with the $200 million of capital that we use to run these innovative finance deals and has been a constant support throughout. So thank you to both of those. And thank you to everyone here tonight for braving the rain and the miserable evening to come out and join us when you could quite happily be watching television or doing something quite warm and relaxing at home. Paul, Cary, and Mukul, thank you so much for entertaining us this evening. And my last task is to say, please join us for some drinks and light refreshment next door. But before we do that, please join me in thanking the panel. Thank you. So it's just out either that door or that door.
That
You have a
man's been
choice.
sipping a glass of red wine all the way through this.
What do you
I just
think
say
of,
that?
what's happening with this?
Yeah, but look, that was just